Thank you very much, organizing committee, and very special thanks to Aditya Chil sir for allowing me to present ahead of him since I have my flight scheduled at 6 o'clock. So my talk is to discuss about the role of conduction system pacing in patients specifically with heart failure and left bundle branch block morphology. These are my disclosures. So normalization of white QRS morphology, be it left bundle branch block or right bundle branch block, is not a new thing. This has been demonstrated by Dr. Narula way back in 1970s, where he has used a temporary pacing catheter in the his bundle zone to correct both left bundle branch block and right bundle branch block. But only in the year 2000, Dr. Deshmukh clinically demonstrated the feasibility of his bundle pacing, followed by Dr. Wang in the year 2018 about the feasibility of direct pacing of left bundle to capture the broad fan of left bundle fibers on the LV side of the subendocardium. Since we are talking more specifically about a subset of population, heart failure population with left bundle branch block morphology, we need to define what exactly is left bundle branch block. Not all white QRS with predominantly negative morphology in lead V1 can be called as a typical left bundle. You need to have certain criteria. The most famous one is the Strauss et al. Criteria, where he has shown that a notch in the inferior leads, 2-3 AVF, or one AVL, any two of the consecutive leads, if it is there, then it favors a typical left bundle branch block. On the other hand, if you see some Q waves in lead 1 AVL or V5, V6, where you should not see in a typical left bundle, it's more of an atypical or so-called intraventricular conduction defect, where the response to CRT differs. So we need to define the terminology and choose the patient for the right CRT modality for a maximum benefit. So way back in 2019, there was a beautiful hemodynamic study where they have shown that the response to his bundle pacing is better than biventricular pacing, and the response to LV septal pacing is not as bad as his bundle pacing. But now we are in the era of left bundle pacing, where the lead can be directed directly into the intraventricular septum to capture the left bundle fibers. But how conduction system pacing corrects this white QRS? So you have learned in physiology that the fibers inside his bundle are already predestined. So I've given yellow color for the fibers going into the right bundle and red color for fibers going into the left bundle. So if you have any segmental disease within his bundle, the patient can have either left bundle branch block morphology or right bundle branch block morphology. So all you have to do is identify that deceased segment and deploy the lead just distal to the site of the deceased, his bundle. So how to identify? We have a lot of electrophysiological markers to identify the deceased zone of his bundle. But more comfortably, if you can deploy the lead in the proximal left bundle, almost 95% of the time, you will be correct in correcting the white QRS morphology. So why the patient with left bundle is having symptoms of heart failure? Because of this abnormal activation pattern. These patients will have activation of right ventricle first, followed by delayed activation of the left ventricle. So this dysynchrony is going to produce LV dilatation and LV dysfunction. So how left bundle pacing is going to work? It's going to directly capture the left bundle so that the LV will be quickly activated. So as early as the lateral wall of the left ventricle is getting activated, there will be a synchronized activation and the patient can have betterment of LV ejection fraction. So this we have shown clinically with the help of a simple dual chamber pacing lead. So this side we have a baseline echo with a very hugely dilated left ventricle almost nearing 8 centimeter. We just used a simple dual chamber pacemaker. The ventricular lead was deployed in the left bundle, and in the next 1 year, he had normalization of the LV function. You can even see regain in the muscle mass of the left ventricle, where the LV is almost normal with a good left ventricular hypertrophy after left bundle pacing. Not only in terms of improvement in LV ejection fraction, but also the functional mitral regurgitation recovers much better in patients who are getting a conduction system pacing as compared to biventricular pacing. The difference between these two echoes is just 10 days. The patient was implanted a left bundle lead for a DCM LBBB, And within 10 days, you can see how good the mitral regurgitation had come down even before the resolution of LV dimension. This occurs because of superior electrical resynchronization, resulting in synchronized activation of the papillary muscles. So that ultimately reduces the mitral regurgitation even before the LV dimensions had come down. So not only in adult population, we can do a conduction system correction even in pediatric population. So this particular kit had a baseline 2:1 AB block with intermittent long pauses, AB blocks resulting in asystole and sudden cardiac arrest. Since there was a baseline left bundle branch block and mildly impaired LV function, we thought of giving a conduction system pacing lead for this baby. So we have a 4.1 front size lead which can easily go into the venous system of the kids. So with the help of a delivery catheter, the lead was successfully deployed in the left bundle zone, and you can see a near normal appearing ECGs. So these are all the patients who are at risk of developing pacing-induced cardiomyopathy in the future. We know once the ventricular pacing burden goes up and duration of pacing goes up, the risk of pacing-induced cardiomyopathy goes up significantly. So when you do a good job of capturing the his bundle or left bundle for patients with a young congenital complete heart block, this is going to help them a lot in the future by avoiding all the pacing-related complications. So comparisons, though we don't have much of a randomized trials, we have some small number of trials which had compared his bundle versus biventricular pacing and left bundle with us biventricular pacing, which had shown that either non-inferior or better results with the conduction system pacing. But we have large number of non-randomized data involving nearly 3,000 patients with the biventricular pacing versus left bundle pacing, where they had shown that the time to death, heart failure hospitalization or mortality was significantly less with those patients who are getting a left bundle pacing lead as compared to a biventricular pacing lead. And the super response is much, much higher in patients who have a baseline left bundle branch block morphology as compared to those patients who have a baseline non-left bundle branch block morphology. The problem occurs in patients with a baseline intraventricular conduction defect, where they will not fit either into the left bundle branch block morphology nor into the right bundle branch block morphology, where we may have to club both the conventional biventricular pacing with the left bundle pacing lead to give a therapy, the so-called left bundle branch optimized CRT. So here we'll be putting the lead in the left bundle and the lead in the coronary sinus, and if required, an ICD lead in the RV apical septum. Not only in terms of reducing the heart failure hospitalization, but also the arrhythmia burden significantly comes down in patients who are getting a conduction system pacing lead. It's not a big surprise because if you are activating the normal cardiac conduction system, because of its superior electrical resynchronization, not only the atrial arrhythmias, but also the ventricular arrhythmia burden significantly comes down when you are going to give a conduction system pacing lead. So even in patients with mid-range LV ejection fraction, for example, between 35 to 50% with a baseline left bundle branch block, the conduction system pacing will result in quick normalization of the LV function. So what we have observed that the more early you intervene in the natural history of the disease, the better the results. The patient will regain their normal LV function as early as 1 month when they are going to get a conduction system pacing lead. So we went one step ahead in risk categorizing these patients with a baseline left bundle branch block. We did cardiac MRI in all these patients who were referred for a device therapy. We categorized them into high-risk group and low-risk group based on their scar burden. If the scar burden is less, in a typical left bundle branch block, we did only a dual chamber pacemaker with a left bundle lead and right atrial lead. And what we could observe was nearly 80% of these patients had normalization of the LV function at the end of 2 years. On the other hand, those patients with a high scar burden, as expected, they had a lot of clinical events in terms of arrhythmias and mortalities during follow-up as compared to those patients with a low scar burden. So here comes the importance of risk categorizing them and providing them a cost-effective CRT, because we are living in India where finances are big restraints. Not all patients can get a CRTD box. Some of them may not afford for even a simple dual chamber pacemaker. So how to predict response? So we are planning for a biventricular pacing or a conduction system pacing for a patient with a LBBB and heart failures. Can we have any way of predicting the response in assessing the therapy? Yes, we have answers for that. The big thing is CAR. The scar not only helps us in predicting the response to therapy, but also in deciding about the modality of CRT therapy. For example, if the patient has a clean myocardium without much scar, so they don't have to really get an ICD lead. No scar means the risk of sudden cardiac death significantly comes down. So you don't have to worry about adding an ICD lead if there is a financial constraint. You just have to use a pacing modality alone. On the other hand, if the LV is totally replaced by scar, for example, sarcoidosis patient, where the LV will be completely burnt out, we may have to not only add the ICD lead, but also promptly refer them for a cardiac transplantation therapy because these patients will not do well with a conventional CRTD alone. So these are some of the examples of scar categorization: no scar, significant scar, and mild scar. Depending upon the distribution of this mild scar, we can plan either a left bundle pacing lead where the lead will be deployed into the septal zone without scar, or a conventional coronary sinus pacing lead when the patient has a significant septal scar. Retrograde conduction in the left bundle, sometimes if the patient comes in the early part of the natural history, they will have an intact retrograde conduction. So that means that the left bundle branch block is unidirectional in nearly 20% of the patient. So if they have an intact retrograde conduction, these patients has a higher incidence of super response, and they had near normalization of the LV function probably within 3 to 6 months. There are a lot of studies available these days starting from 2030 to 2025. In the future, once we get a randomized data, probably this will go up in the guidelines. Currently, the left bundle pacing has been offered a class 2A and 2B guidelines for being used as an alternative for CRT. But once we get a randomized data, probably this will go up, and this may be probably a frontline therapy for patients with any white QRS, be it left bundle or right bundle branch block with a significant LV dysfunction. So this is a quick comparison of biventricular pacing and conduction system pacing. So biventricular pacing has been flooded with evidence almost for 3 decades now. We have plenty of evidences supporting biventricular pacing, but the only limitation with conduction system pacing is the data. His bundle, though it was started in 2000, it didn't kickstart till 2010. But with the advent of left bundle pacing from 2017, you can clearly search in the literature the number of articles getting published on conduction system pacing, the number of randomized trials on conduction system pacing had actually seen a significant jump. So probably in the near future, we'll be all doing conduction system pacing for not only patients with heart failure, but also for patients who had bradyarrhythmia and significant pacing burden. Thank you very much for your patient listening. We'll be happy to answer the questions.